Hello everyone, I am Dr. Muhammad Saleh and today I will talk about high frequency oscillatory ventilation, and I promise you it will be a very nice, concise and comprehensive presentation that will change your idea about high frequency ventilation. We will talk about what is high frequency oscillatory ventilation, indications and contraindications, initial settings, recruitment and weaning. The idea about high frequency ventilation started very early. In 1915, Dr. Henderson said that there may be easily gaseous exchange sufficient to support life even when tidal volume is considerably less than dead space. And as you can see here, this is a historical map for the progress of the idea of high frequency ventilation, which was started by Dr. Henderson in 1915 and ended at 2000 when the FDA approved the use of high frequency oscillatory ventilation for adults. There are four types of high frequency ventilation: high frequency oscillatory ventilation, high frequency positive pressure ventilation, high frequency jet ventilation, and finally high frequency percussive ventilation. So let's think together, what is high frequency oscillatory ventilation? It's a type of mechanical ventilation that use constant descending pressure, which is a MAP or mean airway pressure, with the pressure variations oscillating around the map at a very high rate up to 900 cycles per minute. It creates small tidal volumes, usually less than the dead space, about 1 to 3 ml per kilo. It delivers a constant mean airway pressure without the high peak plateau pressures and the large change in pressure with each breath of conventional ventilator that can be injurious in stiff, non-compliant lungs. High frequency oscillatory ventilation reduces the lung injury. So what are the components of high frequency oscillatory ventilation? You can say there are mainly four components. The first one is a MAP or mean airway pressure, which is creating a constant descending pressure to hold the lung open. A piston, which moves in and out, producing oscillations in the airway that moves the small volumes of gas toward and away from the patient. You have to see here that both inspiration and expiration are active. In conventional ventilation, only the inspiration is active and expiration is passive. But here in high frequency oscillatory ventilation, both inspiration and expiration are active. The third one is amplitude, which is, or delta P, which determines the height of those oscillations. And lastly, the frequency or hertz, which determines how many of these oscillations occur per second. And here let's see together how to start and calibrate this machine. This is a SensorMedics 3100A, which mainly used for neonates and pediatrics, and there is another machine for the adults. Let's see the components for this machine. Here is the flow, here is the MAP buttons, two buttons for MAP, here is the frequency, here is the inspiratory time, amplitude or delta P or power, all are the same. Here is the button and here is the monitor. Here is the monitor for MAP. You set from here and you see here the number. Here is start and stop. Here is the piston position and it should be oscillating around this midline. Here are some alarms. This is a maximum airway pressure and this is a minimum airway pressure. Here you can set the maximum limit greater than 50 and the lower limit less than 20. Here is a silence button for 45 seconds, reset power fail. Here's some lights or lamps for low gas source, overheat or low battery, stop, oscillation. And here let's see how to calibrate this machine and how to start it works. Here is the on and off button. Here we started the machine to work. Here is the flow. Here is the map. We start with the map maximum, both buttons. And here is the flow, usually at 20, and we're not changing this flow. Here is the reset button. We started to press on it. Still the machine not working, just we are calibrating now. Here is a start. We will decrease the map here from this button, and you will see this monitor, it decreasing, it's going down. This is a map. So let's start with a map of 19 to 20. This initial settings for a new NATE now. And here is the power or map or delta P. We'll set from here. We'll start the ventilation now. As you can see, this is a amplitude or delta P 56. It will be guided by wiggling. We will change it according to wiggling, according to CO2. This is a piston position. It should be around this midline. And this is a button for piston positioning, this one. Yes. This is a frequency. For a new NATE or a preterm, we start with a 15 frequency. These are another parts of the high frequency oscillatory ventilation machine. This is an air oxygen blender, and these are some lines. Here is a humidifier, as you can see. Here is a piston positioning, and here is the power on and off. Here is a diaphragm for a piston. This is a short stiff tube which we connect from the piston to the patient. Let's see the demo for a test lung. Here this test lung is connected to high frequency machine, and you can barely see this vibration or this oscillation. It's very fine and very gentle oscillation for this test lung, and this show you the pressure, how low inside the lung. This is the idea of high frequency ventilation, is to give a very, very small volume with a very small pressure in a very high rate, that just to give the lung time to recover. Now let's see the traditional or conventional ventilation. This is a baby log machine, and see how much pressure will be delivered to this test lung in comparison to the high frequency oscillatory ventilation. Look here for the test lung, how much pressure is going to this lung. Too much pressure, especially if you have ARDS, which is a disease of heterogeneity, and you have healthy parts and you have sick parts. So the healthy part will become stiff with these high pressures. Okay. Now let's see how it works and what is the main difference between the conventional mechanical ventilation and high frequency ventilation. Conventional mechanical ventilation, as we mentioned before, inspiration is an active process, but expiration is passive process. And the pressure is oscillating between PEEP and PIP, the positive end expiratory pressure and peak inspiratory pressure. And here is the map or mean airway pressure, as you can see. So this oscillation or this change in pressure is large difference between the PEEP and the PIP. But in high frequency ventilation, you open the lung using the map pressure. You open the lung here and the machine start to oscillate around this map in a very high rate, but in a very small volume and very small pressure. And for more clarification for this idea or for this theory of high frequency oscillatory ventilation, please follow this diagram or this loop. This is a pressure volume loop showing here the inspiration or inspiratory limb. Here is the lowest inflection point. Here is the lung start to open. So here the minimal change in pressure will change the volume significantly. Look here, any change in the pressure will make a mega change in the volume. Then you start the lung to open, then you reach the upper inflection point. At this area, when you increase the pressure, the change in volume is not that much. So this is the area of overdistension. So the area below or before the lowest inflection point or the opening point of the lung, this area is area of atelectotrauma or area of atelectasis, area of collapse. And here in the upper inflection point, the area of overdistension. Here is a safe window between the lowest inflection point and the upper inflection point. Here is the expiratory limb, as you can see, and here is the safe window, the window that if you ventilate the patient in this window, so you are away from atelectotrauma and away from overdistension and volutrauma. So during the high frequency oscillatory ventilation, the entire cycle operates in the safe window and avoids the injury zones. As you can see, this is a safe window and this is oscillations. And here are some theories about how the high frequency oscillatory ventilation works. You can say molecular diffusion, Tyler dispersion, turbulence, asymmetric velocity profile, Bendeloft, cardiogenic mixing, and collateral ventilation. And this diagram showing you what is the frequency or how it works, the frequency. As you can see here in the lower frequencies, you have the area under the curve, which is the tidal volume. This is a tidal volume and this is a tidal volume. So the lower the frequency, the higher the tidal volume, the higher the risk of volutrauma. So in high frequency, usually our mindset to keep the highest frequency as much as we can, because when you increase the rate, you decrease the tidal volume. And here is a major difference between the high frequency ventilation and the conventional ventilation, because in conventional ventilation, when you increase the rate or frequency, you increase the CO2 wash. But here in high frequency, when you increase the frequency, as you can see, you decrease the tidal volume. So you're not washing the CO2, you are retaining the CO2, but you are saving the lung. You are using the lowest tidal volume as much as you can to help the lung to recover. There are too many different types of ventilator-induced lung injury, like volutrauma due to overdistension, atelectotrauma, repeated recruitment and collapse, biotrauma, inflammatory mediators, barotrauma, high pressure induced lung damage, and oxygen toxic effect due to high FiO2. So what are the indications for high frequency oscillatory ventilation? First of all, the inadequate oxygenation that cannot safely be treated without potentially toxic ventilator settings and thus increase the risk of ventilator-induced lung injury. Or you can see failure of mechanical, conventional ventilation. Objectively, you can say if you have a PIP or peak inspiratory pressure more than 30 to 35, this is an indication. FI2 more than 60 or inability to wean. Or MAB more than 15. This is indication as well. PEEP more than 10 or oxygenation index more than 13 to 15. And we will come to details for how to calculate the oxygenation index. So how to calculate the oxygenation index? Oxygenation index recognized as the primary indicator for respiratory disease severity stratification in mechanically ventilated pediatric patient. The oxygenation index equal MAP or mean airway pressure, you can get it from the ventilator, times FI2, you can get it from the ventilator as well, times 100 divided by the PO2, you can get it from the blood gas. If you don't have an arterial line, so no problem. An oxygen saturation index or OSI can be used. Oxygen saturation index equal mean airway pressure from the ventilator times FI2 from the ventilator times 100 divided by oxygen saturation. So how to define the severity of the disease in pediatric acute respiratory distress syndrome? Oxygenation index define the disease severity as follow. Mild and oxygenation index, and here is oxygen saturation index from 4 to 8 and OSI from 5 to 7.5. Moderate if the oxygenation index from 8 to 16 and OSI from 7.5 to 12.3, and severe if the oxygenation index more than or equal 16 or OSI equal to or more than 12.3. We have some relative indications as well regardless of the ventilator setting. In case of acute lung injury or ARDS, in case of air leak syndromes, bronchopleural fistula, congenital diaphragmatic hernia, alveolar hemorrhage, inadequate alveolar ventilation with respiratory acidosis, acute chest syndrome, and sickle cell disease. And in neonates, if there is PPHN or persistent pulmonary hypertension of the newborn, acute respiratory distress syndrome, pulmonary interstitial emphysema, meconium aspiration, and pulmonary hypopresia, all these are indication for high frequency in neonates. Now we know the indications, so what are the contraindications? There are no absolute contraindications for high frequency oscillatory ventilation. However, high frequency oscillatory ventilation can be less effective in high intrathoracic pressure and increased airway resistance like bronchial asthma. It can lead to air trapping, hyperinflation, barotrauma, and air leak like in pneumothorax, pulmonary interstitial emphysema, and pneumomediastinum. It can also be avoided in patients with intracranial hemorrhage and severe sepsis with multi-organ failure. Now let's start using the machine. To use the machine, we have to know the initial setting, how to set the primary setting for the machine. Remember that oxygenation and ventilation are dissociated in high frequency oscillatory machine. You can set the oxygenation alone and the ventilation alone. Now for oxygenation, we use two things, the MAP or mean airway pressure and the FiO2. Start with the MAP, about 3 to 5 centimeter water above the MAP you were achieving with your prior form of ventilation. So if you're using a conventional ventilation and the MAP is, for example, 20, so you add 3 to 5 to this 20, it will be 23 or 25 to high frequency machine, and this will be your starting point, and then you will adjust according to the lung inflation. We will talk about this in the next slide. rapid increase in the MAP resulting in higher intrathoracic pressure and may impair the preload to the right heart, lead to poor cardiac output, and precipitate hypertension or even cardiac arrest. Then the FiO2 start with 100% FiO2, then we will wean progressively and to reach the FiO2 of 60 or 50. After you do the initial settings, you have to do X-ray to check your setting. Here is the optimum for the diaphragm. Usually we're targeting to reach the 8th to 10th rib maximum posteriorly. Here is hyperinflation, as you can see. Now we're reaching the 11th rib, and here is low MAP, and as you can see it's high diaphragm and the lungs not inflated well. You can be generous in using chest radiograph when you apply high frequency ventilation, so you can do initial chest X-ray at 1 to 2 hours to determine the baseline lung volumes on high frequency oscillatory ventilation. The target reps, as we mentioned before, 8 to 10th rep posteriorly. Follow-up X-ray after 6 hours is recommended. You can repeat the chest X-ray with acute significant changes in patient condition. Now let's go for the second part of settings for ventilation. For ventilation, we set the amplitude or the delta P, which is generally set so the patient's chest and abdomen have a generous wiggle. Use 15 to 20 centimeter water above your PIP on conventional ventilator as a general starting point. Frequency is often set based on age. And here is the frequency and the recommended rates that you can start with according to the patient weight. Here, as you can see here, this patient is 1 kilogram or 1000 grams, and advisable frequency to start with is 15 hertz, and the hertz is equal 60 breath per minute. And here for patient more than 30 kilogram, advisable is 6 hertz. Look how much difference from 15 to 6 according to change in the weight. And here in this video you can see the chest wiggles. You can focus on the umbilicus and you can see how fine this vibrations or this chest wiggles. You can accept wiggling up to the groin, but not up to the toes or the head. This is too much wiggles. If you reach the head or the toes, that means you are giving high amplitude and you need to decrease it. But we usually target the umbilicus and we can accept up to the groin. And now tell me, how do you manipulate settings to improve oxygenation and ventilation? To improve oxygenation, either to increase the MAP in 1 to 2 centimeter water increments or to increase the FiO2. To improve ventilation, increase the amplitude or decrease the frequency. Another way to improve ventilation is to let a little air out of the cuff of the endotracheal tube to allow some passive CO2 removal. So what are the advantages of oscillatory ventilation? It reduces the risk of volutrauma and thus helps prevent ventilator-induced lung injury. Reduction in barotrauma as well. Lung recruitment. It also maintains constant alveolar inflation and thus prevents the inflation-deflation cycle. Improved oxygenation and decrease atelectotrauma. Improve gas exchange and oxygenation. So if we are saying that there is a lot of advantages for high frequency ventilation, why we are not using it too much? Why we don't use it in all times? Because high frequency is not a normal way to breathe, and many cases a child must be paralyzed to tolerate it and allow the ventilator to do the work. This can lead to increased morbidity. Additionally, if you are holding open the lungs, it can have a negative effect on heart function. It can decrease the return of venous blood to the right side of the heart and cause hypotension. As previously mentioned, it's not a great mode of ventilation with lots of secretion, because when you insert suction catheter into the airway, you cut airflow, de-recruit all that lung you have gained. And now let's go to alveolar recruitment. Alveolar recruitment by definition means opening up of the closed alveoli. The benefits of optimal lung recruitment: 1. Reduction in the intrapulmonary shunt fraction, resulting in an improvement in arterial oxygenation. 2. Improvement in the lung compliance. 3. Prevention of repeated alveolar collapse and reopening, which prevent ventilator-induced lung injury. How to do recruitment? Let's go step by step. You start with FiO2 100%. Start with your baseline MAP or mean airway pressure, then check the oxygen saturation. Then start to wean the FiO2 gradually until you reach 40 to 50% and keep at that level. While going down gradually with the FiO2, the oxygen saturation probably will drop. So increment the MAP gradually by 1 to 2 at a time, until you reach your target oxygen saturation, or the patient starts to be hemodynamically unstable. You can start with a lower frequency, 8 to 9, then gradually increase it to 10 to 12 in pediatrics, guided by the CO2 elimination. So after you did the recruitment of the lung, you have to know what is the opening pressure of the lung and what is the closing pressure of the lung. So while you are weaning the MAP, after you did the recruitment, you will start to wean the MAP gradually. When you wean the MAP gradually, the saturation will be in the beginning maintained, and at a specific number of the MAP, the saturation will drop significantly, and at this number you can say this is a closing pressure of the lung. Then you have to repeat the recruitment again. Then you don't wean to this number, but you keep the MAP more than the closing pressure by at least 2 centimeter water above this level. Then after recruiting the lung and the lung get better, you start to weaning. You start the weaning process. After the lung recovers and you got acceptable blood gas, you can start this process. You can accept a little bit high CO2, accept a pH more than 7.2, and accept mild hypoxemia, oxygen saturation more than 88, better than having normal blood gas but with very high settings. When you reach FiO2 of 40, start to wean the MAP by 1 to 2 centimeter water gradually till you reach the MAP of 8 to 10. In air leak syndrome, wean the MAP takes priority over FiO2. Keep the frequency at 10 to 12 and don't wean it. Please remember that frequency is the most injurious parameter because it causes volutrauma. For the amplitude setup, target optimum chest wiggles. Wean the amplitude if there is excessive wiggles, if you are wiggling the head or feet, or if there is washing the CO2 in spite being on a maximum frequency, with amplitude by 2 to 4 centimeter water gradually, roughly you can target double the MAP. For extubation, if the patient is doing well with a satisfactory blood gas, then can be extubated directly to nasal CPAP, or you can go back to conventional ventilation. You can discuss this with your consultant. Let's have a look on literature. This is an important observational prospective multicenter study on rescue high-frequency oscillatory ventilation in neonates failing with conventional ventilation, and this was showing a successful rate in 58.1% of patients. On the other side, this study, which is meta-analysis for high-frequency oscillatory ventilation in children, which is telling us that the effect of high-frequency oscillatory ventilation on mortality was not significant. In summary, we can say high-frequency oscillatory ventilation improves the outcome by decreasing the shear forces associated with the cyclic opening of the collapsed alveoli, increased frequency to decrease the tidal volume and decrease the risk of volumetrauma, minimize amplitude to minimize swinging in pressures with inspiration and expiration. Oxygenation and ventilation are dissociated. We still need further studies to prove the advantage of high-frequency oscillatory ventilation over conventional ventilation. And for more interesting medical videos and posts, you can check our channel on YouTube and our page on Facebook. Thank you and goodbye.